Welcome to this explainer on peptic ulcer disease. Today, we're going to unpack one of the most fascinating paradigm shifts in modern gastroenterology. It's a classic example of how modern medicine completely transformed our understanding of a disease, turning what we thought we knew completely upside down.
Think about that awful burning pain in the upper abdomen, the kind of pain that changes when you eat. Sometimes the food helps, sometimes it makes it way worse. Well, for decades, we literally just blame this on stress or, eating way too much spicy food. But we're going to bust that myth wide open right now. Because it turns out, modern medicine discovered the true culprits. Many of these peptic ulcers are actually caused by a tiny bacterium called Helicobacter pylori. It's a microscopic organism that somehow manages to survive our harshest, most acidic stomach environments. That, or they're caused by the frequent use of everyday painkillers known as NSAIDs. This revelation didn't just change how we treat the disease, it completely changed the entire field of gastroenterology.
So here is our roadmap for today. 1. The battleground. 2. Gastric versus duodenal. 3. The culprits. 4. Complications. 5. Diagnosis and treatment. And 6. High-yield pearls.
All right, let's dive straight into section 1, the battleground.
Let's set the stage for how these ulcers actually form. Fundamentally, peptic ulcer disease is exactly what it sounds like. It's a mucosal ulceration occurring in areas that are directly exposed to gastric acid and pepsin. It's the literal cause of that burning pain, bloating, and early fullness. And mostly we're looking at damage involving the stomach and the proximal duodenum. But why does this happen in the first place?
Think of your gut as a literal battleground. Your mucosa naturally maintains this incredibly delicate balance. On one side, you have your protective factors, mucus, bicarbonate, healthy blood flow, and prostaglandins. But on the other side, you've got aggressive factors, gastric acid, pepsin, H. pylori infection, and those NSAIDs. When those aggressive factors overpower your protective defenses, bam, you get an ulcer. It's a simple mathematical equation of acid injury outweighing mucosal defense.
Moving right along to section 2, gastric versus duodenal ulcers. So the absolutely crucial concept to memorize here is the meal relationship. Gastric ulcers, which occur in the stomach, usually along the lesser curvature of the antrum, actually get worse when you eat. Patients might even drop weight because eating is just too painful. But duodenal ulcers, these occur in the first part of the duodenum, and they're actually more common. With these, the pain improves with meals. Food brings relief, though patients do often complain of pain waking them up at night.
Okay, section 3, the culprits. Let's look closer at H. pylori and NSAIDs.
How does H. pylori survive a literal acid bath? It's kind of a genius survival mechanism. This little gram-negative microaerophilic bacterium produces an enzyme called urease. Urease converts urea into ammonia, and that ammonia neutralizes the surrounding acid. It basically builds itself a protective ammonia shield. This lets the bacteria comfortably colonize the gastric mucosa, which kicks off inflammation, ramps up acid secretion, and eventually creates an ulcer.
Meanwhile, everyday NSAIDs, like your ibuprofen and aspirin, cause ulcers in a totally different way. They inhibit the cyclooxygenase enzyme. If you remember that battleground we talked about, prostaglandins are a huge protective factor. By inhibiting this enzyme, NSAIDs effectively turn off your body's prostaglandin production. The result? Reduced mucus, reduced bicarbonate, and ultimately a ton of mucosal injury. Which brings us to section 4, symptoms and complications. Left untreated, this mucosal damage goes from a simple epigastric burning sensation to something incredibly dangerous. You have to be highly vigilant for alarm symptoms. If a patient comes in with hematemesis, which is vomiting blood, or melena, sudden weight loss, dysphagia, or persistent vomiting, they need urgent, immediate medical evaluation. These are major red flags that the ulcer's causing severe damage. So what happens when things go really south? Well, bleeding is by far the most common complication, as the ulcer literally erodes into nearby blood vessels. But you also have to watch out for perforation. This is where the ulcer burns a hole through the full wall thickness, causing sudden, extreme pain and peritonitis. On an X-ray, you'll actually see air trapped under the diaphragm. That's called pneumoperitoneum. Other severe complications include gastric outlet obstruction from scarring or penetration, where the ulcer burrows into adjacent organs like the pancreas, which often causes a really severe back pain. Let's jump to section 5, diagnosis and treatment. How do we fix this? The absolute gold standard for diagnosis is the upper GI endoscopy. It's an incredible tool because it lets you directly visualize the ulcer, control any bleeding right on the spot, and crucially, it lets you take a biopsy. We almost always biopsy gastric ulcers to rule out underlying malignancies, like adenocarcinoma or Malt's lymphoma, which are strongly associated with H. pylori. We can also hunt for the bacteria using a urea breath test or a stool antigen test. Once we know H. pylori is the invader, we hit it with a highly targeted strike. We use a standard triple therapy to eradicate it. This is a three-pronged attack: powerful acid suppression combined with two antibiotics, which are typically amoxicillin and clarithromycin. We also make sure the patient modifies their risk factors, so stopping NSAIDs, quitting smoking, and cutting back on alcohol. And let's look at that acid suppression for a second. The heavy hitters here are the proton pump inhibitors, or PPIs, like omeprazole. These are absolute game changers because they directly inhibit the H+, K+ ATPase pump. Basically, they shut down the stomach's primary acid-producing engine. By blocking this, they rapidly drop the stomach's acid levels, shifting that battleground equation back in favor of healing. Almost done. Section 6, high-yield pearls for your exams. You absolutely gotta know Zollinger-Ellison syndrome. This isn't your standard run-of-the-mill H. pylori or NZ case. This is driven by a gastronoma, a gastrin-producing tumor. This tumor forces the stomach to pump out massive, dangerous amounts of acid, causing multiple, severe ulcers that just won't heal with normal therapy. Also, make sure you don't forget your eponyms for stress ulcers in critically ill patients. A curling ulcer is a specific type of stress ulcer that happens after severe burns. A Cushing ulcer, on the other hand, is tied to intracranial injuries or traumatic brain injuries. Make sure you can differentiate those two. But listen, if you take away just one single fact from today's explainer, make it this: the #1 cause of duodenal ulcers is our microaerophilic culprit, Helicobacter pylori. It's a monumental fact that quite literally reshaped medical history. Peptic ulcer disease proves that what we once confidently blamed on simple stress and lifestyle was actually a hidden, microscopic war. It completely shifted the paradigm. And it really leaves you with a fascinating question. As we've seen bacteria conquer our absolute strongest stomach acid, what other medical mysteries, what other conditions we currently blame on stress are simply waiting for their true microscopic culprit to be revealed? Keep that thought in the back of your mind as you continue your medical journey.